Hello, my name is Lyndon Taylor, and I'm presenting a clinical case of COPD, a patient I saw yesterday. Um, I'm going to call him Mr. Jenkins. He was age 72, a Caucasian male who appeared to be a reliable historian. He said, I'm having more shortness of breath lately with my COPD. So the history has been going on for at least a month. He's got a chronic productive cough that has worsened. He experiences increased fatigue and reduced exercise tolerance. He denies fever, chest pain, and hemoptysis. He uses an albuterol inhaler as needed, but he admits to using it more frequently over the past few weeks. He denies recent illness, but notes difficulty sleeping and daytime sleepiness. He reports poor adherence to his inhaler medications. He has not been hospitalized for COPD in the past year. So his past medical history includes COPD, mixed hyperlipidemia, obstructive sleep apnea, psychophysiological insomnia, and obesity with a BMI of 32. He's supposed to be taking albuterol, 90 micrograms as needed, tiotropium 18 micrograms daily, atorvastatin 40 milligrams daily, supposed to be using CPAP therapy at night, and zolpidem 5 milligrams as needed. He has no known drug allergies. Both his parents are deceased, heart attack and stroke. He's a retired school teacher with a 25-pack year history of smoking. He quit smoking 5 years ago. He lives with his spouse, and there's no alcohol or illicit drug use. For the review of systems, he does experience fatigue and has mild weight gain. He snores. He has a dry mouth on waking. He doesn't have chest pain or palpitations. He does have dyspnea on exertion. He has a chronic cough, but no hemoptysis or wheezing. He suffers daytime drowsiness, but he has no heat-cold intolerance, no bruising, bleeding, and no allergies. Vital signs are normal, except the SpO2 is 93% on room air, and his BMI is 32. His physical exam is normal, except for he has positive sinus tenderness and postnasal drip. And yeah, he reports or he shows anxiety about his sleepiness. Lipid panel is high. Total cholesterol 260, LDL 180, HDL 38, triglycerides 210, and no HbA1c 5.7%. His pulmonary function test is consistent with COPD, 55% predicted FEV1. So the differential diagnosis most likely is COPD exacerbation without infection due to his worsening dyspnea and cough. And asthma is not likely because of the age of onset and because his PFT is not changed with inhaler. He does have obstructive sleep apnea, psychophysiological insomnia, and mixed hyperlipidemia. So the plan is to continue tiotropium, but add salmeterol fluticasone, which is Advair, 250/50 micrograms twice a day, and continue albuterol. His atorvastatin should be increased to 80 milligrams daily. Insomnia, he should taper zolpidem and start melatonin 3 milligrams daily at bedtime, and improve his CPAP machine by going to a specialist and possibly switching to a BiPAP machine. Non-pharmacological, encouraged to keep smoking cessation going, pulmonary rehab, DASH diet, sleep hygiene, CBTI referral, and exercise 30 minutes a day. Should check for education for the inhaler technique, stress the importance of medication adherence, lifestyle changes, as we said, and making sure that he has proper sleep hygiene, consistent schedule, screen avoidance, and calming routines. Follow up in the clinic 4 weeks later for COPD symptom control. Repeat the lipid panel in 2 to 3 months and refer to pulmonary rehab, sleep medicine, CBT for insomnia, and go to the ER if symptoms worsen.